know what I'm talking about. Okay. Now, the reason I think this is a really good topic, because this is the one topic, you know, having a dozen of you out in my clinic here, that it's really often missed. It's probably missed by everybody in the beginning of your training. And it's kind of interesting because if in a different part of the world, you know, somebody comes in with a chronic cough, probably the first thing, if you're in China, Southeast Asia, you're going to think bronchiectasis first before you think of COPD. And a lot of that is because, you know, something like tuberculosis is still the most common infectious disease in the world, you know, communicable disease in the world there. And it's one of the complications that just about everybody's left with after they've had tuberculosis to some degree or another. So think about bronchiectasis. If you have enough time here, I'll show you a whole bunch of slides of bronchiectasis to give you a better idea what it looks like. But until then, just assume you can get an X-ray back. And the radiologist, if he doesn't use the word bronchiectasis on it, how are you guys going to know if you have bronchiectasis? Let's say you're looking at the film yourself. What are you looking for in a CT scan?
It infer the bronchus diameter to the accompanying vessel.
Bigger than the vessel that's next to it. That's right. Some definitions say it has to be greater than 1.5 times the accompanying vessel. But, you know, I think that's a little overgenerous. It's one of those situations, if it's that big, that's like a slam dunk, no-brainer. You probably missed a lot of them in the meantime you got that extent of the definition. Okay.
The inner diameter to the wall diameter.
Excuse me?
0.9.
Say it again.
Diameter of the bronchus divided by, no, the inner diameter of the bronchus divided by the wall diameter of the outer wall is more than 0.9.
And how does that help you? Elaborate.
No, I read it once. I read it once.
You read it once. Okay. I'm not quite sure what you're talking about specifically on that because, you know, the bronchial wall thickness, in my mind, just tells how much inflammation is here. Okay, if the bronchial wall is thickened, the more, you know, usually a bronchial wall in uncomplicated bronchiectasis is very thin. Okay, and complicated, a lot of inflammation, a lot of antigens can be very thick compared, you know, it really has, the thicker, you know, the more dilated, the thicker the wall, the more serious the disease. I've never heard the kind of 0.9 thing you're talking about, but I believe you, I just don't know what you're talking about. So anyway.
I'm not going to measure it.
That's right.
It's not the read index, right?
We'll stick with just if it's wider than the vessel for right now. Now we think about, okay, you see on the CT scan, someone has bronchiectasis. Okay, it can be localized, it can be diffuse. We need to think about categories. So this is where you guys are going to come in on. Okay, you're a patient, we're in the clinic right now. I'm hammering you like I usually do. Let's think about a differential here, patient with bronchiectasis. Categorically, you need to think about, we're not going to get, we'll get down to specifics, but right off the bat, we're going to think about categories. Okay, so somebody has bronchiectasis. Go ahead. Speak up, I can't hear you way back there.
Shape in the sense of the cylindrical and the...
Okay, so you're talking about the type of bronchiectasis, like is it cylindrical, is it saccular, is it, et cetera, okay. Helpful, right, you're gonna keep, the differential is gonna depend on the type, okay, the cause of bronchiectasis will ultimately depend on the distribution. You're right, you know, saccular, cystic, cylindrical, et cetera. We'll get into that a little bit. Before we even get to that point, let's think about things that cause bronchiectasis, categories.
Infectious and non-infectious.
Oh, I think that's a good way to start, okay? I think that's super good. Infectious. Okay, infectious we'll start with here, and then we got the whole rest of the board for non-infectious. This is why I needed a big board. You'll see why here in a little bit. Okay, so we're going to start now. Let's subcategories. We'll get to specifics later, but let's think broad strokes here, okay? Actually, you know, before we get to non-infectious, let's stick with that just for a minute. I like that idea. Infectious causes of bronchiectasis. What are you thinking? What are some of the things that can cause bronchiectasis infectious-wise?
TB,
Excuse me?
Post-TB.
Okay, TB is one of the biggest ones worldwide. Okay, again, our patient population, older patient population, foreign-born patient population, put it high on your list, okay? Now, let's say we'll get more specific in some of these a little bit later on. Okay, somebody else said besides TB, what?
Mac.
Okay, atypicals. Okay, atypicals. Okay, mycobacteria. Other categories of the infectious thing. What's that?
Pertussis.
Pertussis, okay. We'll put that over here. Excellent. Pertussis, big childhood thing, very common, cause of bronchiectasis, good. okay? In the bacterial category there,
The current one.
okay? Well, let's be even a little bit more broader here. Bacteria, viruses, mycobacterium, fungus, okay? Let's think about those, about which ones of those we have to be concerned about, okay? So over here, and over here we'll say virus, okay? Are there any specific ones that you need to be concerned about more than anything else about those categories that might lead to bronchiectasis? Excuse me? Aspergillus, okay. We're gonna actually, okay, we'll put that one over here for now. Okay, Aspergillus. Now Aspergillus, if you're gonna bring that one up, you gotta talk about multiple categories of that one. Aspergillus does a lot of things in the lung, okay? So we're gonna actually have a primary infection from it.
Or ABP.
ABPA, exactly, okay. We have invasive, we have ABPA. Okay, we'll kind of come back to, we'll just kind of do some broad strokes here. Some of the viral things. What kind of viral things can cause TB? Or, I'm sorry.
HIV.
How does HIV do it? Good. What's the cause of HIV? Is it just an idiopathic type thing, or is it felt to be due to something specific?
I don't know.
It's actually felt to be more due to the immunosuppression, the chronic infectious type thing. There are some reports it's more, sometimes it's they can't find the infectious thing, but I think most people feel it's probably just due to the infection, the immunosuppression itself that it causes. Any other viral things you're thinking about that might cause that?
Adenoviruses.
Big one, adenovirus. Okay, good. Any other ones? Adeno.
RSV.
Not so much. That's one people usually get over with. That's good. You think it would be as intense as it is in little kids. That comes into play with a couple other things down the road, though. Okay. Excuse me? Not rhino. What's the big one we get every year we have to worry about?
Influenza.
Influenza. Influenza is associated, if you get a bad enough case, with bronchiectasis. Okay? So put influenza. Okay. Now, I think the interesting thing about influenza is that back when I was your age, there were still a lot of people alive from the big epidemic back in the late 1917, 1920, around that area. Kind of killed a good part of the world's population. World War III troops are moving back and forth, transporting it all over the world. And back in the 60s and 70s, some of these, they were the old vets from World War I back then, but there was a lot of bronchiectatic guys back then that had really bad cases of influenza, sailors that was going around the ships, and they were just devastated the rest of their life. Not even the guys who were exposed to phosgene and other gases, which that's a whole other category. I'll come up later on. Okay, but yeah, so influenza, you have to think of that. Any other virus things you guys can think about? We don't see it so much anymore, but it's been in the news a lot lately.
Measles.
Measles, exactly. That used to be a very common cause, later in life, of bronchiectasis. And it wouldn't surprise me if these kids that are getting right now, a certain percentage of them are going to end up getting, later on, showing up in their 20s and 30s. It's something we don't even think about in the histories anymore, bronchiectasis. Because just about everybody that's over the age of 65 had the measles on their own. It was way pre-vaccine. So those are the big viruses right there. Okay. Pertussis, we talked about bacteria. Any other bacteria that you really think in your mind, if somebody has that, they might be at risk of bronchiectasis? Most bacterial pneumonias don't do that. People get them, they heal up, they get a consolidation, they do fine after that. Are there any particular ones you need to think about? Staph. The necrotizing pneumonias. Exactly. Staph's a big one. Give me some clues here.
Klebsiella.
Pseudomonas is a big one. Klebsiella. Those are two big ones also. Pseudomonas. Klebsiella. And don't forget a big category, very common, is the necrotizing strep infections. Okay, they get in the lung. Strep's is one of the big ones also. We don't see it so much with strep pneumonia, but there's a lot of streps out there that, that can do this sort of thing. Aspiration type things, anaerobic infections in the lung. Okay, so these are the biggies. Again, when you see a patient that has this, especially when it's localized, patients like this, unless it's the viral ones, the bacterial ones, usually it's more of a localized process. They have bronchiectasis in the lower lobe or maybe bibasilar. That's when you really got to go into the history of when they were younger. What happened to them? One of my common questions I ask these patients when I go in the room and look at these guys is, let's go way back. You ask, have you ever had pneumonia that's saying, I said, wait, let's go back. When you were a kid, did your mother ever tell you you were like really sick? Did you ever miss school? Back in the pre-antibiotic era, there's a lot of old people out there before the before they had penicillin. When was penicillin invented? When did it come into play?
1939.
When was it become into common use? wasn't until about the mid to late 1940s. In the late 1940s, it was still such a rare commodity that when they found out these soldiers were getting wounded in World War II and they're having these horrible infections and things, it was such a grand commodity at that point and so valuable that they would take the soldiers' urine and concentrate the penicillin to use it again. That's what a rare commodity it was. Okay, and so before that 1940 era, patients that used to get these bad pneumonias when they were kids, they don't remember it right off the bat. You have to kind of really delve into history. And a lot of them will say, oh gosh, yeah, I remember I was off school for 2 or 3 months, or oh, my mother said I had real bad bilateral, double pneumonia is a term they used to use a lot. Those were terms they used to use like they were really sick. So you got to get histories. If you have histories like that, then you start, you start to get clues that make sense. And then you get even more into the history. Well, did this cough really just start 2 months ago, or have you always had like a little bit of a problem? And a lot of times the story goes back a lot further than just your initial superficial history that you got the first, like when you're in there for 15 minutes. It always really shocks me when you guys go in to see your patient for the first time at the consult and you come back to check it 20 minutes later. Wow, I'm like, geez. I mean, I'm in there for like 40 minutes. So sometimes you really have to go into depth, though, to get a lot of this information. Okay, now, so we talked about the mycobacterium, we talked about bacteria, we talked about viruses, the fungal stuff. What are some other fungal things you need to think about here? Histo. You're going to see more histo than you're going to see people with old TB in this area. Southeast Michigan has been a swamp for 30 or 40,000 years. It's always going to be a swamp, okay? If we just put a lot of homes on it, septic pumps and things, or septic tanks, not septic tanks, but sump pumps and things like that in their basements, okay? Probably 4 out of 5 cases, when you see the granulomatosis, the hyaluronopathy with calcifications in it, more often than not, it's going to probably be somebody exposed to the histo. What kind of, and histo, think of it just like tuberculosis. It does the same thing long term, okay? A lot of them end up with bronchiectasis, along with that adenopathy in the hilar region. Now, when they get their bronchiectasis, not only can occur from the infection, but what's the other common cause of bronchiectasis? It's not just the infection itself destroying the lung, causing scarring, contraction, bronchiectasis. There's another phenomenon. It happens in TB. It happens in histo. You guys might give any clues here? Suppose you look at they have a collapsed right middle lobe, or they have one lobe. They have bronchiectasis, and they have one lobe that's kind of like really atelectatic. You see some calcified adenopathy on the CAT scan. What's the cause of bronchiolith? Not just the bronchiolith, but especially right middle lobe syndrome. Worldwide, okay. Remember, the middle lobe is the smallest of all the bronchial tubes. There's a lot of lymph nodes around it. Takes very little to compress that rascal, okay? Then you get a post-obstructive bronchiectasis. Very common to see right middle lobe syndromes. When I see right middle lobe, one of the things I first think of is throw a PPD on the patient, look for calcified adenopathy on there, get a histo history. What kind of things give people exposure to histo? Tell me what the different things, especially in Michigan, we see so many people like this. Not everybody grew up on a chicken farm. Not everybody grew up, spent the summer at grandma's farm. That's one of the first questions I asked. Well, just about everybody did spend the summer at grandma's farm back 50 years ago. Every grandma had chickens back then, but what?
Chopping wood?
Chopping wood, exactly. People that chop wood, it's not just chopping wood themselves. I think one of the best cases I saw here just a couple of years ago was a young woman who went with her son out to a wood yard to collect firewood for their little wood stove they had, because they just love the smell of it in the winter to do this kind of stuff. So they would pick up the wood themselves, drop it in her trunk, and what happened to her was she presented to a primary care doctor with an asthma-like picture, that she kept giving her steroids over and over and over again for the asthma to make her feel better. Chest x-ray looked pretty unremarkable. Came to us months later, we did a CAT scan on her, and showed this little ground glass, very little bit up in the upper lobe region. We were concerned about that. Geez, what do we do about that? If I remember, I think we did transbronchial biopsies at that point were negative. And we wanted to go further. She decided she wanted to go to California and visit somebody or other, so she kind of took off for a couple months, goes to California, hits the ER like every 3 weeks, get more steroids all the time. And anyway, she finally came back a few months later, repeated the CAT scan, and now there's like a few more really fine ground glass areas. We finally just sent her for an open lung biopsy, and she had histo every place. And this occurred about 3 to 4 weeks after collecting all this firewood. and putting it in a trunk and hauling it home. So, you know, wood, not just wood shopping, collecting firewood. What's another way you can get it in this area? Excuse me? Say louder.
Caves.
Caves, okay. How do you get in caves? A spelunker.
Spelunking, yeah.
From what now?
Hikers.
Well, caves, where does it come from in a cave? Bats.
Bats.
Exactly. And interesting little tidbit of information I found the other day when I was reading about this. We know that TB is common, it's an upper lobe disease in people. Where does it occur in bats? Very common in bats too, by the way. You get TB from bats. Where does it occur in bats? Exactly, it's in the lower lobes because they're hanging upside down most of the time. Exactly.
Higher oxygen tension.
Actually saw a picture of an X-ray of a bat that had tuberculosis. It was upside down there. It was in the lower lobes. Okay. Anyway, okay. Other ways you get histo.
Sawdust.
Not just sawdust, but we saw a bunch of cases here not too long ago as a
Construction.
result of all the flood damage we had last year and the year before. Okay, what will happen is, again, you know, get flooding, the sump pumps stop working, basements flood, a lot of these basements are finished off. People have to go down there and start tearing out all the walls and the wood paneling, tear out all the carpets, they're in an enclosed spot. Remodelers come to see histo there. Some of the most impressive cases I've seen were people that were tearing out, just remodeling their house as a result of old water damage in there. You have to think of that also, okay? So just about anything exposure to that's rotting, whether it's just wood, materials, carpeting, very high risk factor, especially in this part of the country. Because we just, as I said, we live in a swamp. It always has been and it always will be. We just built homes on it. Okay, we think histo, suppose we lived in Louisiana or Minnesota and you had the same history of exposure. What are you thinking of there? Chopping wood, like camp? What's the fungus there? Blasta, exactly, blastomycosis. Okay, actually, that looks very much, it's very hard to tell them apart. But histo and blasto, blood tests are kind of worthless for the most part with these. Histo, you get the urine antigen and stuff, it's a fairly recent test. The blood test for histo antigen or histo antibody. Again, when I was your age, we used to draw those on everybody. You know, does everybody get this stuff? And I don't think I ever saw one that came back positive. Also, you know, the reason pathology, people used to order those routinely up to about 2 to 3 years ago. Finally, pathology refused to start or refused to run them in people. They just quit doing it. So I had to call them up all upset and frustrated one day. What the hell's going on here? This is pre-Epic, so we couldn't blame Epic for it at that point. And the pathologist says, yeah, we went through all our records here, and we never found a single case of a positive blood test for histo and all the ones we had over like 20 or 25 years, whatever. So they just finally just let people draw. So it shows how worthless those things turned out to be. But we used to draw them all the time, hoping we get lucky. Okay, we talked a little bit about the atypical mycobacterium, and these come into play here a little bit later as we get to other categories. So we hit the infectious stuff pretty good here, okay? Let's move on down the road here. Non-infectious stuff.
Dr. Moss, I have a question.
Sure.
Urine histo.
What's that?
Urine histo antigen.
How often is that positive?
That's
Anybody know? Active case of histoplasmosis, how often is the urine actually positive?
Yeah, I think it's something in the 80s.
I thought it was more in the 40s. That's why I'm asking you guys. Last I read, I thought it was in the 40s. But, you know, let's find out about that. If somebody could Google really quickly on that one. I thought it was pretty low, actually, in active infection.
So true stem doesn't rule out.
You what now?
The true stem doesn't rule out.
Exactly. I mean, when you got it, it's a slam dunk. When you don't have it, well, you're just kind of back where you started from. Okay. Let's talk about the non-infectious. This category, notice I got the whole rest of the board here, because that's a lot bigger stuff. That's actually the more fun stuff. Let's categorize now the non-infectious stuff. How are we going to think about those? Break it into categories. Think about something you know that gives cystic fibrosis and give it a category.
Yeah, sensitivity is pretty high.
What's it say? Oh, sensitivity, but...
yeah, so the sensitivity is in the mid-80s to 90%.
Is that the urine or the blood?
Urine.
Good, okay, I didn't know that. That's good to know. Excellent.
So it's the opposite. It's a good
So
screening
it's a
test.
good rule-out test.
Now, is that in the acute febrile phase, or is that, because there's a lot of chronic ones in there also.
I'll look it up.
Yeah, let's find out about that one, because you know, a lot of times when you see histo, if you see the fulminant one, I believe that for sure. There's a lot of these ones that are just kind of slow, indolent, kind of chronic type stuff, you know, too. It can go on for a long time. That's a good question, and we'll find out the answer, okay? Non-infectious things, categories. Let's talk about categories.
Clearance problem.
Think of a disease and we'll put it in categories.
Cystic fibrosis.
Cystic fibrosis, okay.
Cartilage.
Excuse me?
Cartilage.
Cartilage disease.
Cartaginers. What is cartaginous?
Primary ciliary
It's a
dyskinesia.
severe,
Okay. And what's associated with it?
it's
Fertility.
50 and that's
Sinus
in
inversus.
vitro.
Strep.
You're both right. It can be situs inversus and just dextrocardia, okay? It can be any combination and above. It could be a partial thing. Here's an interesting thing. Question. You have two twins, identical. One has cartaginous. The other one have to have it also?
Penetrance is variable.
It's variable. You're exactly right.
Yeah,
Because the
but
other one
these
might
are
not have.
identical twins.
What's it? They're identical twins, but the other one might not have it at all. So there's something else that happens developmentally. They may have the same tendency of the cilia type thing, but they don't necessarily have to get the sinus inversus. Okay? There have been recorded instances of a twin, they might have the little cilia thing, but one has sinus inversus or dextrocardia, the other does not. That has been documented. Okay? So there's a little more to it. There's some developmental aspects that come into the congenital aspect of the genetic aspect as well. Okay, so we're going to have, let's put this category here called congenital.
Oh, I like that.
And we're going to say, okay, well, instead of we'll say congenital and genetic. Okay, let's give these two separate categories. Okay, genetic, we're talking about, like we just said, cystic fibrosis. The things that we know are definitely inherited, because when I say congenital, there might be a defect that just appears in that one person. Something happened developmentally, congenitally, that he's got this, he's born with it. Okay? This is going to break down, actually, you know what I'm going to do? Because that's going to break down into other categories too. I'm going to need more room. So let's do that. Let's say the genetic over here, and put cystic fibrosis there, and then we're going to have the congenital. Now, let you know, this congenital is going to be a real big category type stuff that we're going to run over into. Okay, so we said cystic fibrosis. Now, let's talk a little bit about cystic fibrosis also. Okay, there's the classic form we all know about. There's, how many different phenotypes or genotypes are there of cystic fibrosis now been identified? Anybody know?
1,600.
Is it that many?
Mutations.
I was going to say hundreds, but
1,600 mutations.
because I don't know for
1,600
sure either,
different
but
mutations.
I know it's way up there.
1,600.
1,600 different mutations.
The
How
oldest,
many phenotype?
well, I don't even know that. But let me put it this way. The oldest patient I've had that I diagnosed cystic fibrosis in was 66.
Wow.
I've diagnosed it in 50-year-olds. I've diagnosed it in 40-year-olds. Okay? But the older they get before you find it, the more bizarre the mutation is going to be. There's going to be a milder variant of it. But let me give you and it's going to be harder to diagnose because the sweat chlorides in these milder cases that can have lung disease are not always positive. Okay? The genetic tests, when you order them in the chart, those are only for the classic ones. You miss the other ones. It's really like pulling teeth with our pathology department to do when you think somebody really has it, to have a full genotyping of what's going on, to look for these other things. I've had no luck with our people doing that, quite honestly. Multiple tries. I ended up sending them down to Children's Hospital, the DMC, where they have a CF expert, and she knows how to really finagle and threaten their lives, and has all these research grants to get the phenotyping. But now, a good example was a lady that I saw. It was actually a fellow's case about 2-3 years ago. And she was like 52 or 53, and she was sent to us, not so much because of her chronic cough, but because her x-ray, somebody thought she had ILD. Okay? Got an x-ray, first time in our system, got a chest radiograph. Looking at this lady, real nice woman. She had a couple kids who were grown already. Okay? She had this x-ray, that I could see why they read it as ILD. The fellow says, I think I got an ILD case, we need to do a biopsy. I said, I don't think so. Okay? We went in and did the history, and her history was pretty classic. She really did, to her it was a lifelong thing. She didn't think much about it, but yeah, I've always got a cough. I always produce low phlegm. I've had it since I was a little girl, okay? So then you go into the questions about, well, you know, did you ever have bad pneumonia, pertussis, measles, all that came into play here. But here was a lady that had this diffuse, you can see the little tram tracks on there. You can see like little like ring-like structures on there from the bronchiectasis. Did a CAT scan, fairly classic diffuse bronchiectasis. At that point, tried to do the sweat chloride, came back, you know, she had to go down DMC, it came back negative. We're still pretty convinced of it. So our lab wouldn't do the stuff, so we ended up calling the DMC gal down there. She ran it. Sure enough, this lady, she actually had 2 different genetic variants that are very mild. to classify her as cystic fibrosis. So here's a lady that was a very mild, she actually had children, she wasn't infertile. So again, there's a lot of variance. The older they get, the milder it is. It's something you still have to think about. The sweat chloride may be negative. Okay, so what are some of the other genetic things we need to think about? The pure genetic, not congenital, just pure genetic. You got an abnormal gene, we've identified the genes, this kind of thing.
Primary ciliary dyskinesia.
Okay, is that one we've actually identified the genetic abnormality? The genotype on?
No.
Well, we have it on that one, but that probably is a genetic one, sure enough. Now, when we talk about, I'm going to put that one over here under congenital for right now. Primary ciliary dyskinesia, okay? Again, that's like cystic fibrosis.
They also are infertile and
Excuse me?
infertility is also associated.
Right, now when I say it's like cystic fibrosis, what I'm referring to is that there's so many different variants of it. When you talk about ciliary dyskinesia, what we need to talk about, this is a cilium.
67 plus 3 tubule formation, I think, or something.
Say that again?
57 by 3.
There's actually nine
9.
tubules groups around here, okay?
Yeah.
There's 9 of these, okay? There's actually 2 in the middle, and these kind of go all the way around. 1, 2, 3, 4, 5, 6, 7, 8, 9, okay? Now, each of these tubules, they have like little spokes that come off, okay? They also have an outer Didion arm. They have an inner Didion arm that goes all the way around, okay? Whoops, the inner one kind of goes inward. You can have a defect of any one of those points. That's been described at every level of this. The tubules themselves, the spoke-like structures, the Didion arms, even in the center ones. If you look at cilia, electron microscopy, or even under video microscopy, these things are all, the whole group of them, they're all lined up at pretty much the exact same angle. They cannot vary this angle by more than 25 degrees. If they do, they have ciliary dysfunction. In other words, they all beat just the same way, okay? If they're not lined up, if there's something, and that's another whole category of diseases they don't line up correctly, okay? So there's a whole family of these things. How do we diagnose them when you have them? Okay, well, you mentioned how they show up. They show up as infertility in males, okay? When they have the bronchiectasis, is there anything kind of characteristic about the story on these guys besides just bronchiectasis? What are the presentations that they commonly describe? Other ailments that go with that?
Sinusitis.
Sinusitis, what's that?
No, I said sinusitis.
Sinusitis, good, exactly. Sinusitis, other things associated, mastoiditis goes along with it.
Oh, yeah.
A lot of infections, the ears, the mastoids, the sinuses, they have a lot of those. Okay, mastoiditis isn't that common anymore. This thing to be antibiotic. So again, somebody has sinus problem, mastoiditis, put that high on your list. Okay, infertility in males. Females tend to have a little bit more success getting pregnant with this than males do. Okay. When we talk about primary ciliary dyskinesia, like I said, the whole family of these guys, but what else falls in genetic and congenital? Let's talk about some more of those.
So congenital, there's Meunier-Kuhn.
We'll come to that one later. I like that. Okay, we're going to put over.
Repeat again.
We're going to classify those guys.
Meunier-Kuhn.
Yellow nail syndrome. There was a question on that on the boards.
We're going to get to that one also. Absolutely.
It's there.
Yeah, they always put one of those on the board.
They don't spend that.
Yellow nail?
Yeah.
That's a whole question.
Let's try to figure out how we want to categorize these. Okay, let's do the congenitals as either, we're going to say these are, okay, we talked about congenital, we're going to put this over here. We talked about the ciliated. Okay, ciliated is primary ciliary dyskinesia. Okay, let's make another category up here. Let's call this cartilage. And let's put another category of connective tissue. Okay, now Sarah, we're going to put your Meunier-Kuhn. Tell us what Meunier-Kuhn is.
Congenital tracheobronchomegaly.
I don't even know how to spell the damn thing.
K-U-H-N.
K-U-H-N. Okay.
I'm recording you right away.
Okay, Meunier-Kuhn. Okay, go ahead. Tell us again how you present.
Congenital tracheobronchomegaly.
Okay, tracheobronchomegaly. Okay, big
Airways.
Big airways. What's the cousin of this disease?
Cousin.
That looks like this, but it's a little bit different distribution. But whenever you talk about There's always confusion with Meniere's-Kuhn versus his other entity. When you start out, you look really closely at the CAT scan. Anybody know what that one is? What's that? I thought you said it actually.
Is it the tricutal combination or something?
It's got a couple names. Well, yes, but it's got a real name. Okay.
It starts with a W, doesn't it?
Yes,
I don't
it
remember
does.
what it was called.
Williams-Campbell.
Williams-Campbell, yeah.
Williams-Campbell.
Something Wilson.
Not a girl. There you go. Come through for me. Okay. Okay. How does Williams-Campbell differ from Meniere's-Kuhn, you know?
That I don't know.
Okay. Williams-Campbell is more peripheral. Okay, it's the large airways, the greater distribution. When you see tracheomegaly with a big mainstem bronchi that are hugely dilated, that's Meniere's-Kuhn. It starts early. Actually, it may not even show up till 20s or 30s, but it usually does start usually in adulthood to get really bad. Okay, that's felt to be basically I put it under cartilage, but it kind of probably overlaps on the connective tissue disease there. But it's loss of cartilage in the airways. Now, how you can separate Williams-Campbell from the other bronchiectasis, diffuse bronchiectasis out there, is Williams-Campbell tends to be more of the bigger airways. Yeah, it can be peripheral, but like ABPA, you don't expect to see the right mainstem bronchus dilated.
Central then.
So Williams-Campbell, as you get a little more proximal, those get dilated, you're kind of more proximal than you normally see the peripheral bronchiectasis. So big airways, trachea, think of Williams or Meniere's-Kuhn. It gets down in the mainstem bronchi, trachea is okay, moves out peripherally. You talk about the Williams-Campbell syndrome, okay? Now let's talk about ciliated epithelium. Did we hit everything I wanted to talk about? We talked about Cartaginers. Let's put on here Cartaginers. How do you diagnose the ciliated dyskinesias? What do you do for those?
Electron microscopy of the nasal mucosa, or the nasal.
Right, biopsies of the the electron microscopy biopsies are probably the ideal way. Other methods that we don't have availability here, and very few centers do, is what they call video microscopy, or the saccharin stimulation test. You know, it's solution of saccharin makes the cilia beat really fast. Problem with some of those other tests is if somebody's had a sinus infection with a relatively close period of time, the cilia aren't going to work anyway. So things like a saccharin test, if you do those and it works, in other words, it beats the cilia, you don't have it. So it's kind of good for excluding, but you got to be careful with it because if there's been ciliary injury or damage or infection, it's not so hot. Okay, cartilage, we hit the two big ones there. Williams-Campbell. The problem, one of the things that you got to think about too, is these are a nightmare for transplant. It kind of makes sense they would be because you got to try to connect those big airways to try to connect a normal size one that's all ballooned out, looks like a total mess. Also because of the blood supply to that area from the dilation and things, they fail really high. So there have been experience with that. Let's talk about the connective tissue ones, okay? Now this is where you have, kind of makes sense to think about things that affect the connective tissue that you're born with. Think about categories again. We're going to get to that in autoimmune disease, another category. We're going to move down to autoimmune here a little bit. But we'll get to those in a minute. We're not there yet.
Isn't it the same?
That's a whole other category. Okay.
The fibrosis around the airway that causes.
Nothing about fibrosis, but connective tissue diseases that you're born with. And there's a whole bunch of them. What am I thinking about?
Yellow nail. That was on the boards.
I know.
It was terrible.
Let's come back. She keeps coming to yellow nail. Where are we going to put yellow nail? That's a good one. Yellow nail. Okay, we'll jump out these other ones. You guys can think about that. But Sarah's right.
It's under the congenital category.
It goes in the congenital category. That's right. That's the yellow nail syndrome.
What it is?
Who can tell me what yellow nail syndrome is?
So I don't remember a whole lot about it, but it was.
They
They get yellow nails, and it's something in their lymphatic circulation that's problematic.
Right.
And they get chylous effusions, I think, right?
Right. They get
Something like that.
They have
Yeah.
peripheral edema.
Mhm.
They have the pleural effusions. The yellow nail, of course, on that. And actually,
And then they asked they were asking a question, I totally don't remember, but they were asking a question about the pathology. So something about what the lymphatics look like on there. They got a picture of a toenail that was yellow, and then asked you.
They actually had a picture on the boards. Is that right?
Yeah.
Wow.
So that was D or C?
It was D.
If you don't know these, oh my god.
Now, along with the yellow nail, you also have to think about, I forgot one here that I kind of wrote down on here, is Young syndrome. Did I talk about that at all?
No.
Okay, Young syndrome, actually, we'll put that over here because it looks so much like cystic fibrosis. No one's really been able to document a genetic abnormality with it, but it does look exactly like it, but it's associated also with azospermia. There's actually a variant of it, they don't call that. They don't call it Young syndrome, but you actually have absence of the vas deferens, and it shows up with bronchiectasis. So there's kind of a weird entity here, Young's, and the other one is kind of similar to it. Young's is azospermia, total absence, doesn't really have a name on it, but they throw it under Young syndrome. I've never seen those myself, I must admit.
Is this the one related to mercury?
No, I don't think that's related to anything at all, as far as I can tell, or as far as I've read on that. Well, we have a whole bunch of things we kind of didn't even get to. We'll have to make more categories here. Okay. That's the category we missed. I just realized that. Okay. We're going to run out of room over there. So we're going to put over here the congenital ones.
I think it could be for genetic.
I was gonna say.
So you guys didn't realize there's such a big thing on bronchiectasis, did you?
Immune deficiency, yes. Remember that
Okay.
case?
Let's talk about the congenital. Okay. Go up in here. Let's talk about the immune things you were just talking about. Okay. Now, we'll break this into category of humoral.
Oh wow.
And we'll break it into cellular.
No.
Yeah. I'm just getting warmed up, guys. Let's talk about the humoral type things that can happen. Okay, that give bronchiectasis.
Chronic granulomatous.
There you go. The granulomatous is associated with a common variable immunodeficiency. Okay? CVID, common variable immunodeficiency. Okay. Now, here's the question for you. Is that genetic or is that just something acquired?
Can be.
You're right, keep going.
It can be either.
It can be either,
Yeah.
exactly. It can be either. We talk to allergists here, they think everybody is genetic, but I know I've had patients where it showed up 30, 40 years later in life, they developed CVID, sarcoid like pictures go along with it. So very often, it's not unusual to see a sarcoidosis picture with this. Okay, let's talk about some of the other humoral things. Okay, you mentioned agamma-globulinemia, okay? Specifically, what are the, elaborate a little more into agamma-globulинemias. Let's talk a little more about those guys.
The IgG4.
There's a whole category of these. Okay, so the one I think you're probably specific to, what we call the agamma-globulinemia, is that X-linked, or what's the other name for that? Bruton's. Oh boy. Good. Okay, Bruton's. Okay, we're gonna need more room up here. Cellular over here.
I cannot even read it.
I'm going to run out of board here in a little bit. Okay. Some of the other ones. You mentioned about the IgGs. Are there immunoglobulin deficiencies or diseases, bronchiectasis, associated with which type of immunoglobulin deficiencies? There's a whole bunch of them out there.
IgG.
Okay, right there. You can have the total one, IgG2 and IgG4. Selective deficiencies of those, you can see bronchiectasis. That's probably one of the more common ones you see. Those two things. It's really unusual to see bronchiectasis with just an IgG1 or an IgG3, but the 2 and 4 combination is associated with it. We will give replacement therapy for that with the globulin infusions. I've had a fair number of those over the years. How do you diagnose it?
You just get the you order the.
Total IgG level and subclass.
Yeah.
Give them the vaccine, and then recheck the.
Right. Well, first of all, you have to establish they have low gamma globulin levels.
Okay.
Right. So you draw the the panel is an IgG, an IgM, and an IgA. They give you together. Okay. Now you can still have a selective deficiency of IgG2 and 4 if with normal levels, low normal gamma globulin levels. Okay. So you have to do the IgG subunits or subclasses. The IgG 1 through 4 to pick those up. So whenever if you think, that kind of drives me nuts because a lot of times I see patients at fellowscene and they draw gamma globulin levels. IgG comes back with normal 700, comes back like 705 or something, and they forget to do the subunits. If you're going to do one, do the other because they really kind of complement each other. Okay, and then.
You give them like normal vaccine.
Exactly.
And check the response.
Check blood levels to pneumonia, to H flu. Give the vaccines. How long do you wait after you give the vaccines before you check the levels?
Like 6 weeks.
Yeah, it's about 6 weeks. That's good. Attaboy. Good for you.
Check an initial level, you give the vaccine, then you check another level.
Yeah, you see the
You want to
response.
see if they respond.
You want to see if they like quadruple, quadruple 4 times increased fold over their levels before you started. Often, you get a really important clue in an adult that tells you he has bronchiectasis, and I've seen this happen. He's had his pneumovax given before, like a few years before. You draw his levels, it's like nothing across the board. And that's a pretty good clue also. You still give him the vaccine, but if somebody's had the vaccine and you still see low levels, you pretty much know what you have before you give him the challenge. Okay, because he has had the vaccine before. And that's become very common in older people that have the pneumonia vaccine. Okay, other immune globulin type states that can do it. Are there any, this is one I like. Are there any increased immunoglobulin states that lead to bronchiectasis?
Hyper IgE.
Yes. Now, how many types are there?
Four.
no, actually, right, there's probably several of them, but yes, there is an IgG syndrome. Let's see, make sure I get the right name on it here. I didn't write, Job syndrome. That's what I was drawing a blank on. There's a Job syndrome. There's actually an autosomal dominant and autosomal recessive form of it. And what's felt to be the cause is it basically impairs cytokine synthesis. These high levels, things like IL-17, interferon, tumor necrosis factor. The IgGs, that's how they're felt to cause bronchiectasis. And they have levels. I had a patient with this once. I mean, we're talking about levels of IgE like 8,000. I mean, they're like way up there. Okay. Hyper IgM, forgot about him also. Hyper IgM syndrome can lead to bronchiectasis. I don't know if anybody understands the mechanism on that. So we mentioned in here, increase IgEs, increase IgM. Okay, well, there's another really deficiency we didn't talk about, hemoglobin. It's part of the regular panel, IgA. Don't see those very often, but if you think about it, that's the one that's found in the secretions. So people with IgA deficiencies, okay, the IgMs are increased, the IgEs are increased, but the IgA, that's another syndrome. Is there another disease we've all read about in medical school? I don't think anybody's ever seen one. Another name of, excuse me?
Another name for what?
People that have a immunoglobulin deficiency. Little kids, they're born with it. Yeah. It's picked up later on by CAT scans of the chest and things like that. And
George?
The Georges, exactly. Thymic the Georges, okay. Okay, right, they have the total thymic on that one. Okay, we haven't talked about the cellular ones yet. Let's talk about the cellular ones. How about those? Any ideas on that? Those are really rare ones. I have to look at those myself, guys, because I can't remember them. And you don't see them very often. But we'll just, for the sake of time, I'll just give you a whole bunch of those. So things like severe combined immunodeficiency states, which is called Aldrich syndrome, cartilage hair hypoplasia, you see a dwarfism. So if somebody's a dwarf, they're very susceptible to getting bronchiectasis. Certain types of, it's usually the short-lived dwarfism. You should see that with. I think I mentioned ataxia telangiectasia, a little more common, but those are ones that kind of have combined immunoglobulin cellular deficiencies, and I'm not going to write them down. There's so many of them. Okay, so we talked about the immune deficiencies. We talked about, we went back to the connective tissue. We didn't get that far there. We also talked about there. Excuse me?
What about that one antitrypsin?
We forgot the big genetic one. That's right, alpha-1. That's one that's worth talking about, okay? Because lots of studies have been done. There's some big centers that have bronchiectasis clinics. National Jewish Hospital, National Institute of Health. When they look at their huge populations, they find that not just in patients with cystic fibrosis, but there's some fairly high percentages, 2 to 3 times the normal population. Well, they will have variants of the alpha-1 antitrypsin gene, okay? The people that have the mycobacterium clinics at National Jewish Hospital with bronchiectasis with that. Again, they find not only high incidence of the alpha-1 gene, but they also find high incidences of people having an abnormal CF gene, much higher than the normal population. So keep that in mind. Okay, there's been other places, studies out of France, like for example, one that claims they don't see that at all. but it's been well documented in multiple studies in bronchiectasis clinics. And what's all about that? I don't think anyone really knows at this point. We do know that alpha-1 antitrypsin, some weird things happen with that when you have the variants. For example, like the Z phenotype, when it polymerizes, is a chemoattractant. Okay, so in other words, it's something like it's irritating to the bronchial tree. It attracts neutrophils and a destructive reaction. The other thing that's kind of interesting is about the alpha-1 antitrypsin thing. It seems to give a protective effect in people that they've actually done studies of people without bronchiectasis, just bad, chronic bronchitis and things like that. They've also done emphysema studies just by using the alpha-1 antitrypsin enzyme. And there's actually been studies to show improvement, less incidence of infections and things doing that. It's not approved for that, it probably never will be, but just kind of interesting things, little things that are done on the side. Okay, so we talked about alpha-1. Oh yeah, we got a whole bunch of categories we haven't hit yet. Okay. Autoimmune. What are the biggies? That's the biggie. Rheumatoid arthritis. Okay. Depending on who you read, you're going to get a different opinion on this one. Okay, really variable. But overall, people just have random, with rheumatoid arthritis, random CT scans, just general among everybody's symptoms or not, you're going to find about 8 to 10% incidence of bronchiectasis in those patients, and not necessarily associated with fibrosis. That's the manifestation, that's how it presents itself. Okay? People that have symptoms, respiratory symptoms, that have CT scans of rheumatoid arthritis, you're going to find about a third of them have bronchiectasis as the only entity or as the primary entity, not associated with fibrosis. Yeah, we do know that rheumatoid arthritis probably has more lung involvement than any other connective tissue diseases, the things that could do NSIP, UIP, COP, rheumatoid nodules, bronchiectasis, NSIP, I think I mentioned UIP. So a lot of things happen with that, but bronchiectasis is real high on the list with that one. Okay, how about some other connective tissue diseases? What else do we see it with?
SLE, Sjogren.
Sjogren's, big one. Forget my J name now. Okay. Sjogren's is kind of a really weird entity. Because the question is now, why does Sjogren's do it more than any other? In fact, whenever you see diseases like lupus, okay, when you see diseases like lupus and rheumatoid arthritis that has bronchiectasis, there seems to be a really high incidence of them also having Sjogren's as part of the manifestation. Then the question is, so why does Sjogren's seem to have more of a problem with that, with bronchiectasis? Think common sense here. I've seen lots of Sjogren's with bronchiectasis. Why would that be, you think?
Dryness.
Right. They got all this mucus abnormalities, the dryness, things just don't work right, they can't protect their lungs as well, so it's not surprising to see a higher incidence of bronchiectasis in those individuals. Okay? Anything is associated with anything else? The
Polychondritis.
Polychondritis, absolutely. You see it there. And that's a cartilage defect, so we could actually probably throw that one over here also. Excuse me?
Mixed connective tissue.
Yeah, the mixed connective tissue diseases, anything that has, the feature of the rheumatoid or Sjogren's. Lupus by itself, it's not really common in, but if it's associated with the Sjogren's-like syndromes, then you'll see it happen in the lupus-like syndromes. But usually it's got to have the overlap to it. Okay? Some of the other ones, autoimmune, that we don't know, we'll throw in there also. Sarcoid, let's not forget about. Okay, traction bronchiectasis can occur there. Obstructive phenomenon from sarcoid, the big nodules, obstructs airways, causes post-obstructive bronchiectasis. Bowel diseases is associated with any of the bowel diseases?
IBD, yeah.
Inflammatory bowel
disease.
Okay, any ones in particular? Is it all of them, or just one in particular?
Crohn's.
I actually got it backwards, but nice try. You tend to see it more in ulcerative colitis than you do in Crohn's. Okay, you can see it both, but it's usually more common in ulcerative colitis. Okay, I think we hit most of the highlights on there. Okay, now, big category we missed. Two big categories.
There's more.
Oh my gosh, yes. Like I said, this is why I wanted to talk about this, because, when you guys are in the office, we see the patient, you guys can think of 2 or 3 things.
I'd be lucky if there's 5
So, again, it's like my physiology lectures. My job is to press upon you how much you really don't know, make you work a little harder and study a little harder on this one, okay?
ABPA, we have.
We didn't talk a lot about ABPA, but
Let's
that's right.
get
We'll
up
throw that on the phone
messages.
for now. You guys kind of know enough about that right now. So we want, you know, eosinophilia, the IgE, they have asthma with it, this kind of thing to make the diagnosis. So that's kind of the common one you guys think of. Well, let's put in two other categories here. Let's put in inhalation and also obstructive.
Oh, yeah, that's right.
Big categories. Okay. Now, when you talk about inhalation, let's break that into groups also. Okay. What are some of the groups we can break into with inhalation? Running out of time here, but okay. Go ahead. Toxic, exactly. We have the toxic things. Now, toxic can fall into multiple categories. Inhalation gases, you know, some of the common ammonia, chloride, things exposure to the industry. You see that around here, not uncommonly. People have had an industrial accident. It's very common. Somebody told you, I've had a cough for a few years. They kind of forgot, yeah, gosh, we had a spill back at work, whatever, you know, when they had to evacuate 40 people out of there, you know, chlorine gas and stuff like that. Every now and then things like that will pop up. Metal fumes, cadmium, aluminum, nickel. Okay, some of the heavy metals also fumes. They can be pretty toxic to lungs and cause bronchiectasis. Okay, so we'll talk about gases, we'll talk about fumes, okay? And we missed a real big one here we got to throw into there, and that's aspiration. Okay, aspiration, multiple things happen. And that you have acid, you have infection, you have food particles. All those things can cause damage. Along with the aspiration, the things you guys don't think about very often, let's, you know, you think about the real, you know, sudden kind of recognized episode, but there's a lot of neurologic diseases that impair swallowing, esophageal function, gastric diseases, things can happen in sleep. You know, it's not unusual to see people with chronic neurologic disorders, myasthenia, MS, you know, chronic ALS type syndrome that don't kill people, last for 10 or 20 years. They have esophageal dysfunction. Things kind of get up in there, give them trouble, okay? They aspirate it slowly, so think about those things. The obstructive. Actually, let's call it post-obstructive. Makes a little more sense. Okay, post-obstructive type stuff. And what are we thinking about there? Actually, there's three big categories here. Okay.
Tumor.
Tumor, that's one of them. You got it. Tumor. What else?
Foreign body.
Foreign body. Yeah, boy, good for you. Foreign body. Okay. And the one we talked about in the very beginning.
Right middle lobe.
Right middle lobe, but something that obstructs the airway, whether it's not a foreign body or tumor. It can be from extrinsic compression, from adenopathy. It can be bronchostenosis from old TB or histoplasmosis. Okay, something that causes obstruction and or compression, we'll call it. Okay. Talked about toxic. We talked about thermal. We talked about ABPA. I think we hit most of them. I tried to write as many down here so in case we wouldn't forget any major categories. I think we hit all the major categories. A bunch of little ones I kind of skipped on here, the kind of the rare things. Okay. Well, good. We're kind of running out of time. But anyway, I wanted to give you an appreciation. When you think about bronchiectasis, let me see it. Unfortunately, I don't have time. I had a bunch of slides and stuff. I thought I might have time to show it at different types of bronchiectasis. But basically, a lot of this, the distribution helps you a lot on the CAT scan. You know, if you have something that's very diffuse all over the lung, you think of something that's gone on their whole life, something genetic or acquired, you know, or not acquired, genetic or born with congenital. Okay, it's been a long disease process. You think of something immune type of deficiency. We have whole categories of that, the whole middle of the board there. Okay. So history becomes important also. How long has this been going on? It's a lifelong process. It's been going on for a long time. You have the autoimmunes are usually a lot easier to figure out, but don't be fooled by the autoimmune either. I've had patients, let me give you the classic example. In fact, Nadja, when she was a fellow, she had her clinic at us really nice, Dr. Buda. And one of our very first patients, this was a guy that had been to like whole bunches of pulmonary guys before and other doctors and stuff. He had this chronic cough, he had bronchiectasis, you know, pretty classic in the case. He was kind of pissed off at the University of Michigan because they were kind of blowing him off and stuff. So he came to us because I guess his neighbor came to me or something, I don't know what it was, something like that. And anyway, again, going through this workup, we did a connective tissue disease workup. And this guy's rheumatoid factor was like in the thousands. He had no symptoms at all. So basically we told the guys, we weren't sure what they needed to see there, but bronchiectasis can show up years before the connective tissue disease does. Okay? And this is a situation we simply told the guy, this problem had gone on for 2 or 3 years now. So we told the guy he had Pseudomonas in his sputum, the whole shebang. Look, yeah, all the other workup was negative. So we basically told the guy, don't be surprised if one of the days you wake up in the morning and your joints are all swollen, you're just feeling kind of miserable. And it was really funny because coincidentally, about 3 weeks later, he calls Naja. Naja comes running, being all excited. He woke up this morning and said, oh my God, my hands are so swollen, I could hardly move them. I mean, he had like a really massive acute attack of rheumatoid arthritis. That's how it started. And that's how he presented. So connective tissue disease category, that can kind of fool you, but the serology can be positive years before. So if they have it associated with that, doesn't mean they have it, but you know, it's something to put high on your list. You know, all the infectious things, you think about the childhood things that might have happened, you know, how far back does this go? Did they have something really terrible that insulted them early on, especially if it's a low bar type process, okay? TB, it's not unusual to see people with bronchiectasis, that's the one really associated with massive hemoptysis years later in life. And I've had a few patients over the years where they just have recurrent major hemoptysis, old TB infection, bronchiectasis, often the middle lobe, the ligula. That's a resectable, that's a surgical disease. You can cure that person by doing that. And, okay, of course the workup is dependent on, you know, if you think they might have one of these, you gear your workup towards that. And on that note, what do you say we call it a day? Yes.
That's great. Thanks, Dr.
Thank you.
And you just thought there's 3 or 4 things.